Welcome to the Lipid MAPS Podcast. This episode is sponsored by Merck KGaA, Darmstadt, Germany. I'm Matthew Conroy, and today we're joined from the other side of the world by Anne Bendt, who is Deputy Director of SLING, the Singapore Lipidomics Incubator at the National University of Singapore. So welcome, Anne, to the podcast.
Thank you, Matt, for having me.
Firstly, what is a lipidomics incubator? What happens at SLING?
Yeah, we get that asked quite a lot. So an incubator, if you think about an incubator, what do we incubate? So we say we incubate lipid ideas. So we are a research program anchored at the National University of Singapore, and we have about 25 people and a whole range of really nice mass spec instruments, from like low resolution to high resolution, and then all sorts of different chromatography, and like a really nice setup. And this combination of this nice technical setup with this very strong research base of lipidomics researchers, we use that as an incubator to incubate lipid ideas, lipid problems, and really go from blue sky research into applications. So it's an incubator for lipid ideas, basically.
Yes, covering the whole gamut of methods development and testing and all that kind of thing.
Yeah, in the true sense of being an incubator, we are very open. So pretty much everything we do is in collaboration with others. Primarily clinicians and biomedical professionals. Also, well, at least before COVID, we've been very, very open to visitors. So we've also been incubating lipid ideas of others from who are not part of us full time, but about a third of us before COVID typically were visitors, short-term visitors, PhD students from other programs, or people from companies who would come stay with us for a while, or more established researchers who would come with their own fellowships or other funding to stay with us for a while.
These are people from all over the world?
All over the world, yeah. Yeah, all over the world. And some of them, we never let them go again. So some of them, we make them stay. So yeah, we used to run this training course, which we called IC Lipid, immersion course, or IC, because I then, see. IC Lipid, it's like a 1-week training course. And a lot of the people who came for this training course later became visitors. And then some of them even permanent members. Yeah, I hope that now that COVID is not that much of an immediate problem any longer, we can resume this and open up again to visitors.
Yes, well, there are worse places in the world to be than Singapore, I think.
Yeah, it's a pretty nice place to be, especially if you deal well with humidity. For our mass spec facility, we had to install additional air cons because the normal air con just wouldn't do the trick.
Yes, I can imagine that would be an issue.
Yeah.
But there have been big changes at SLING recently, haven't there? Can you tell us something about those?
Yeah. We recently had a change in leadership. So we had many here in the LIPID MAPS community are probably pretty familiar with Markus Wenck.
Yes.
Who brought lipidomics to Singapore nearly 20 years ago, 2004. And he's also the founder of SLING. Markus recently in August left Singapore for other adventures. Yeah, we have that caused an interesting time and some changes. And now we have a new director, Professor Yung Wong Choi, who's a long-time collaborator. And that's quite a good. I'm quite happy about that. He brings with him an additional interest in metabolites and metabolomics. So we, as SLING in Singapore, we continue to do lipidomics, but we expand to other, small molecules and metabolites, and we continue to do lots of preclinical research. But we will also expand towards food sciences. Interesting. Yeah, quite interesting.
So I'm just trying to work out where to add the M for metabolites in the acronym SLING. SLING doesn't quite work, but
it's true.
That's the direction you're going.
We'll figure that out along the way.
And you were telling me you're doing more clinical lipidomics now, in addition to research?
My personal main driver really is the clinical application. I'm super, super interested in anything that can be moved out of the research lab into an application, clinical translation, basically. And that's a steep learning curve because, as researchers, we are so hardwired to look for the really interesting things, right? We want to deep dive into really interesting things that then you put a PhD student on it and you publish it well and you write another grant, get more money and dive deeper into this really interesting thing. But that doesn't really mean that it's anything useful for clinical application, right? Because what the clinicians say is it's not enough to be interesting. It needs to be really useful.
They need a result.
And they need to know what to do with that result. And that was really a huge eye-opener by shout out to Professor Dr. Michael Vogeser from Munich, the Ludwig Maximilian University Hospital in Munich, who's one of the pioneers of clinical mass spectrometry in Europe. He always said, interesting is not enough. It needs to be useful, which means which doctor is ever gonna order that test? And what is this doctor then gonna do with that? Is it actionable? Let's say a doctor orders any test off the test menu. What is she then gonna do with the test result to change the clinic, like on the clinical pathway? How's the doctor? How's she going to use this test? And where is it really going to make an impact in the journey of the patient? So yeah, it needs to be useful.
Yes, that's I guess a key thing. If a doctor gets the results but has nothing to be actionable from that, then
exactly
it's not worth doing it. Yes.
Well, it's still worth doing it as blue sky research, right? So we need that. We need the people who are good in that, and then we need the others who find the real clinical need and a gap in the clinical pathway and then develop promising, let's say, biomarkers or so into a really useful test.
Yeah. So could you give us an example of a useful test? Maybe been developed there or maybe more generally?
Yeah. So there is no lipidomics test, right? So if we talk about, if we define lipidomics as we measure like all that there is in lipids, that doesn't exist. Like, I don't think anywhere in the world anyone would ever order a lipidomics test, because then what, right? What do you do with that result? Lipidomics is fantastic in preclinical research, but not really as a readout in a hospital as a diagnostic test. But how lipidomics has really helped towards developing diagnostics is in all these preclinical research and the research cohorts. And one example that is very often mentioned in this context is are the ceramides. The ceramides are bioactive lipids that have been shown more than 10 years ago to be probably pretty good markers for cardiovascular disease risk. And that was based on lipidomic experiments, lipidomic studies on different cardiovascular disease cohorts. And then the ceramides turn out to be those molecules with the strongest predictive power for risk of cardiovascular diseases. And then the researchers who discovered these ceramides as strong risk predictors, they were partly from a company, Zora Biosciences. And I think that was one reason why these molecules actually made it out of a research lab into a real application, because a company was behind it, which had an interest in driving this forward and financed this quite expensive additional validation studies in many, many more thousands of different patients and cohorts. And then soon after, these researchers published the ceramides as a new risk predictor. The Mayo Clinic licensed that assay. And now there's even a second company, Quest, who has also licensed an updated version of this test. So at the moment, it looks like this might be one of the few examples of a successful translation from lipidomic research into a medical test.
No, that's really interesting. And if the test comes back that says, I have a high risk of cardiovascular disease, what's the clinical outcome? What do I do? More exercise, less exercise?
Yeah. How actionable is this?
Yes.
Right? Yeah, so you go to the doctor, you get your ceramide level checked, and then they're too high. Now what? Because they are not entirely actionable yet, because the guidelines are lacking. So the guidelines for how to manage cardiovascular risk, they do not include ceramide-based risk management yet.
Right.
There are certain drugs that you can take that lower your ceramide levels. So in a way, that's actionable. But what's still needed is randomized trials, right?
Yes.
Where you really have patients and you treat one arm according to the conventional risk management, and you treat the other arm according to the ceramide-based risk management. And then many, many, many years later, you check for the outcome. But you can imagine how expensive these studies are, because they take
exactly.
very long, right?
Yeah. And I guess there's the question, is the ceramide levels a symptom or the cause? So if you're just reducing the ceramide levels, you may not actually be changing the disease progression.
That's true. And for many biomarkers, it's clear that they are just associative. But for ceramides, it looks like they're actually causative. So some ceramides cause apoptosis. And it looks like they actively lead to plaque formation. So if you cut open those arteries and look at the plaques, there's lots of ceramides deposited in those plaques. So it looks like they're actually causative. And there are some very promising results with certain drugs and compounds in animal experiments. So stay tuned. Stay tuned.
So cholesterol gets painted as the bad actor in cardiovascular disease, but actually there's more bad lipids in the arsenal.
Yeah, but what's interesting about the ceramides is they're not all bad. They're like not so good ones and good ones. So it's not all about reducing all of them. And that shows you also a huge advantage of mass spectrometry, that with mass spectrometry, you can look at the individual species and really figure out which of those, whatever, 25 or whatever ceramides we have in human plasma are the ones that are the not so good ones, and which ones are the good ones. And then you can calculate a ratio and a risk score to stratify the patients on a scale of 1 to 12 or something for this different risk categories.
So absolutely vital to have lipidomics and the incubator to develop this work.
Yeah, so we were not involved in that research, I must say. I'm just using this as an example.
But the sort of thing you could do easily, because it's a complicated area.
Yes, and so we helped with organizing international ring trials to harmonize this method. Because another problem for translating research is that, let's say we develop a new method to measure whatever biomarker. Who in the world can really replicate these results, because our methods are not really harmonized? So internationally, there's quite a interest now in the world of lipidomics, of course, to harmonize methods and to organize these international interlab studies or ring trials, whatever you call it. Within the International Lipidomics Society, we organized a ceramide ring trial for precisely these 4 species that the Mayo Clinic licensed. So the results will be published very soon.
Excellent. Well, we look forward to that. And Anne, it's been a fascinating talk into hearing about lipidomics in the clinical application and all the changes that are taking place in SLING at the moment. So thank you very much.
Most welcome. Hope to see you in Singapore. Come to the Lipid Symposium, 5th to 8th of March.
We'll see you there.
See you there.
Thanks for joining us in this Lipid Maps podcast. I hope you'll tune in for the next one. Bye.